Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, producer of Paincast and an executive at the Pain Science Division. Should you go for surgery if you have an ACL tear? What is the difference in outcomes if you pursued surgery versus rehab? What does the current body of evidence suggest? Join us on part 1 of my in-depth discussion with Dr. Linda Truong, who has extensive experience in research and practice in this area. Part 2 of this interview focused on evidence-based ACL rehab. Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division nor the Canadian Physiotherapy Association. Enjoy the episode. Hi, Linda. It's so nice to have you on the podcast. It is a very interesting and exciting topic to talk about today. Thanks for joining us. Can you introduce who you are, what you do, and what a typical week looks like for you?
Hi, Tiffany. Thank you for having me on this podcast. I am very excited to be here. As Tiffany mentioned, I'm Linda. I'm a physical therapist based out of Vancouver, Canada. And my main area of clinical focus is sport injuries, orthopedics, and musculoskeletal pain. But specifically, I see a lot of patients with traumatic knee injuries, such as ACL injuries. And I just recently finished my PhD last year. Currently working on a postdoc looking at health systems and how to improve patients with MSK pain and how they access care. So really trying to get patients with MSK pain out of the emergency departments. So really exciting stuff. And so my typical week looks like actually 80% research and being in a research lab, and then 20% clinical. So I am in the clinic once a week, treating mostly patients with knee injuries.
Awesome. So you just finished your PhD. What was the focus of your PhD?
Yeah, so my focus was looking at the psychosocial aspect after having a knee injury. And my PhD mainly focused on social support. So your environment and the people around you and how they affect or motivate you to exercise.
Okay. That's a very unique aspect of ACL management that I guess not a lot of people think about, but certainly in this interview that we'll talk about it as well. Why are you passionate about the topic of ACL management, and why do you like to see patients with ACL injuries?
Yeah, it's an interesting question. I was very fortunate to be able to work in a multidisciplinary clinic when I graduated in 2011. So I worked at the Glen Sather Sports Medicine Clinic in Edmonton, Alberta. And we worked with surgeons and sport medicine physicians and physios. And there was just a huge amount of patients that had ACL injuries. So I think I just naturally fell into what you would call, I'm not an expert, but like a knee expert. And so just saw a huge volume of patients with ACL injuries. And the biggest thing that I've noticed with rehabilitating a patient after an ACL injury is that it's such a long journey. It's not just 5 months or 6 months. You end up spending so much time with these patients. So I was just trying to improve a patient's journey recovery or their trajectory. So in any way, as a therapist, I could make it just a little bit more enjoyable, a little bit more fun, then I think I was successful. And that was really one of the motivators for me going back and doing a PhD. Asking questions more related to the psychosocial aspect, because I think that was a huge burden on a lot of patients that we actually don't talk about, is the mental aspect of having such a significant knee injury. And that's why I decided to research social support, because so many of my patients love just having a really good network and different people around them to help them recover. It kind of made intuitive sense to look at that and the social relationships.
Mm-hmm. You were working with Dr. Jackie Whitaker in Alberta and then now in BC, and involved a little bit with the OptiKnee work that she was doing as well. Can you talk a little bit about how you're involved and what you kind of got out of it?
Mm-hmm. So I sat on the OptiKnee as a research trainee as well as a clinician partner on that project. So just bring a more of a clinical lens. And it was really neat to see a bunch of different people all around the world who's very similar passionate about improving recovery outcomes long term in patients with knee injuries come together and try to develop a consensus and summary of how we should approach these injuries, because there is really nothing available. There's a lot of clinical practice guidelines for rehabilitating ACL injuries, but very few on how to delay or prevent osteoarthritis after a knee injury. So it was really neat to see all these different people. And so one of my jobs was to make sure that whatever we produce was relevant to the clinician. Because as you know, lots of research are published each day. And a lot of my colleagues always remind me that some of the stuff that's published isn't relevant to them or isn't published in a way that is practical. And so we really wanted to have patient and clinician partners involved in the Opti so that we can have a better chance of implementing those studies or the consensus we develop into practice.
I'd like to say, so far as what I've read from the Opti documents and presentations, they're really, really well made. And there's always sections making sure that it's clinically relevant and summarizing the recommendations. So I find it to be a very well done job of how you translate the knowledge gathered from evidence to the actual clinical world. So thank you for doing that. Let's get into the topic a little bit. ACL management. What are currently the different routes that people pursue once they have an ACL injury?
Yeah, so I like to tell people that there are three options usually. So after an ACL injury, and we're assuming maybe a complete rupture of the ACL, there's kind of three options. There's this early surgery, this delayed surgery where you have the ACL surgery later, or just doing rehabilitation alone, which we call non-operative or non-surgical. We've moved away from calling this conservative treatment because I think conservative has a negative connotation where patients are getting second best care. I've had a patient say to me, "Oh, I'm only getting conservative treatment." But really, you are still getting a high quality treatment or intervention. It just doesn't involve surgery. And so if you read across the evidence base, you'll see this shift where we stop calling things conservative management and really encouraging people to say non-operative, non-surgical, because it's a very good option for some patients.
And I guess delayed surgery can be an option after you pursue rehab.
Yes.
So 2 or 3 kind of different management options people take.
Yeah. So and I'll explain them a little bit in detail, where early surgery is kind of that person where most likely they're going to benefit from surgery. And I'm not going to say this is the young person, but it often is the potentially younger person pursuing maybe higher level elite sport that requires a lot of pivoting. So you know that there's going to be great demand on their knee joint, and you want to optimize and give them the most stability as possible. So you're most likely going to follow this trajectory of having surgery once the knee is all settled and they're ready for surgery. The delay surgery are for those that I find are the ones that are not really sure they want surgery. And for me, I see a lot of those where maybe just the timing of their life. And so then we want to trial a bout of non-operative, right? So just rehabilitation, and then determine with really good an exercise prescription program, and they commit to it, that whether they feel like they've regained stability and function in the knee. And from there, if they don't, perhaps they do need surgery, or they continue down the trajectory of just rehabilitation alone. And then finally, there's a group of people who do really well with no surgery. There's some patients who are very adamant they don't want surgery. And so it is fair to just try rehabilitation alone as well. And just because you've chosen one apart from early surgery doesn't mean that you can't cross over. So I spent a lot of time with patients on the first few weeks after an ACL injury, trying to explain that there are different options beyond just surgery, and that you necessarily don't need to make a decision like today that I need surgery, but just to help them be more informed of their future decision. Because many of them do not know that non-operative or rehabilitation is an option.
Yeah, that was what I was going to ask. Like, what do people currently believe when they hear that there are 3 options? What are their thoughts and feedbacks you have found typically?
So lots of patients will look on Google, and I would say North America and probably Australia, we see a high percentage of people with ACL injuries having surgery. So then the perception is that if I have an ACL tear, I most likely will need surgery. That may be perpetuated obviously by media and sports, because every athlete you also know will have surgery like really quickly as well. So I think a lot of patients are shocked They are like, what do you mean? I want to play sports again. So I do need my ACL reconstructed. And I think just bring awareness that there's other options and laying out on the table maybe what are the pros and cons, but also giving them time to make that decision. Because usually after an ACL injury, especially in Canada, because we have a socialized system, people really want to get in the door right away and on the trajectory of seeing a surgeon if they do need surgery. And so they feel like they need to decide immediately after an ACL injury. And so I usually just try to encourage patients that regardless of what path you decide, you still need to do rehabilitation. So you still need to do some exercises to optimize that knee. And then you may find that you may choose a different trajectory or treatment option depending on how it feels in 2 to 3 months.
Before we jump into a little bit more of the research evidence comparing early surgical versus rehab first, I was wondering for you or best practices, if someone do want to pursue surgery early, what are the criteria for the knee before they can do that?
So if we look at, like you mentioned earlier, the Opti-Knee consensus, they give some nice guidelines on what the criteria is if we should have surgery. So the first one is pretty much I call settling down the knee. So we don't want to have surgery on an acute knee. So we want the patient to restore their range of motion, pretty much get rid of that swelling, normalize their gait. So they should actually look pretty normal day to day. That's like my biggest criteria, is that it almost looks like day to day you did not have any injury. And then we do want them to go through a progressive loading exercise program. So load it pretty hard because we need to restore like the strength in the whole lower extremity. So that usually means, I would say, at least 12 weeks of a strength training program in the gym. And then from there, that's probably a better time to then reevaluate, okay, what do you want to do? What's your capacity like mentally and physically to commit to the next step? And if it's surgery, is it a good time in your life? So I think there's a lot more planning than people realize. So it's not just like, my knee feels good, let's have surgery. I find that if we don't take the time to really set up the patient for success, which includes like, do you feel like mentally you're able to handle 12 months plus after the surgery of rehab? Do you have the financial means for rehab and going to the gym? Do you have a social network that can support you, drive you to appointments, things like that? And if we don't discuss that, then we actually set them up for failure post-op and then don't do as well. So those are kind of some of my criteria, as well as the Opti-Knees. Settle down the knee, make sure it looks pretty good day to day. And then I have a serious talk and ask them personally, like, what do they want? Because their goals may change. So really, what are their goals? And do we need an ACL to achieve those goals? And that may help us to decide whether or not we should have surgery or not.
Yeah, so for even early surgery, and we're not talking about you have a rupture a couple days later, get that attached. We're talking about 3 months.
Yes.
And delayed surgery, I guess, in the literature will be anywhere after 3 months that people decide to have delayed surgery. Is that accurate?
Yeah, so it depends on the trial that you are looking at. So some trials you'll do maybe about of 8 weeks of rehabilitation, but most of them will have a longer. The delay group will be closer to, I would say, like 6 months of rehabilitation. And then from there, if there's still issues, crossing over. So the delays, if you get that option, is like you just pretty much are doing rehabilitation to the point where you feel like your knee's not good enough and you want to have surgery. So there's no absolute timeline. And that's where the challenging thing is, that rehabilitation alone really is going to always break into 2 groups potentially. One where no one ever has surgery, and then one that maybe has surgery in the future. So I don't give people a timeline because it's really hard to predict who falls in which group.
Yeah. All right. So now getting into the evidence of what the literature has done in terms of comparing early surgery versus rehab first. I guess we can call them primary surgical versus primary rehab. That's what I've read. Or terminology-wise, what has been the common terminology for these groups?
I find it's just easier to say early surgery versus non-surgical.
Okay.
So you can just think of it as one group that has surgery, one group that doesn't.
Yeah. So comparing early surgical versus non-surgical. On a high-level overview, where's the research at with comparing these options, and what have been the overarching recommendation from research?
So there are 3 high quality randomized controlled trials that are currently available that are published. And there's 2 ongoing trials out of Belgium and Netherlands. And so essentially all these 3 trials, they have kind of 3 groups. They have the early surgery. So within 2 to 4 months, you had an ACL tear. And so you're kind of like randomized to having surgery right away. Again, once after their knee is all settled. Then you have this other group that is randomized to delayed. So then you're just going to do rehabilitation alone. And then if your knee doesn't feel good with just the rehabilitation, then you have this option of crossing over and having surgery. What is interesting is that this third group always appears after, because there's this group that just continues and stays in the rehabilitation, or let's say like just rehabilitation alone. So we end up with what I would say 3 groups always. So all the 3 studies, so there's one that we call the Canoe trial out of Denmark, the Compare trial out of Netherlands, and the SNAP trial out of UK. The conclusions are quite consistent that there are 3 groups, like a third that's going to need surgery, a third that ends up having delayed surgery, and then a third that ends up just being non-operative or rehabilitation alone. And then each study has a little bit of nuances. So for example, the Canoe and the Compare, they looked at acute ACL. So ACL tears within 4 months versus the UK trial or the SNAP trial, they want to look at non-acute ACL injuries. So people needed to have an ACL injury that was over 4 months. So looking at more what happened if you had a chronic ACL tear and you were randomized to these groups, what would you do? And so there was a little bit more heterogeneity in that group because some people had ACL tears up to 10 years that were in the trial, which is actually very interesting. But again, all groups found that if they looked at their outcomes, generally all groups were similar in terms of, say, their patient-reported outcomes, going back to activity or sport, their osteoarthritis at 2 years. So all the outcomes, the clinical outcomes that we're interested are all very similar. Some of them have like nuances where the Compare trial showed that the group that had surgery early slightly reported maybe better perceptions of their symptoms, knee function, and ability to participate at 2 years, but it wasn't clinically significant. So even though we see a significant difference, say, in some of the outcomes, it wasn't clinically significant. And so I think that's an important thing when we read research. We can find something statistically different, but what does it mean clinically? And that's actually what was found in both the SNAP trial and the Compare trial, that yes, the surgical group seemed to be better, but on a clinical perspective, we don't know if it's a big deal or not. So really the conclusion at this point, based off the evidence, is that there are 3 options and people seem to do well in either option, depending, again, on a bunch of different factors, which we are going to talk about. So assuming that surgery is the best option for every single person is not evidence-based, but also assuming that non-operative or just rehabilitation alone is also not. And the pendulum seems to be swinging back and forth to the extremes. And I think based off a lot of these findings, it's saying, yeah, there's actually maybe 3 options. And we need to discuss that and give our patients an opportunity to maybe try, if they don't want surgery right away, that, yeah, rehabilitation may be a valuable option for some of them.
Yeah. Before we're digging into a little bit of the factors that would facilitate the choosing of either options, you mentioned a little bit about statistical significance and clinical significance. And for those who aren't super familiar with these research terms, what does that mean? Like, why can something be statistically significant but not clinically? And how do we determine that? How do we interpret that?
So the difference between a statistical significance versus a clinical significance in research is that when we are looking at a statistical significance, we are running some sort of statistical test. And this is where people have heard of p-values. So a p-value is really a way that we can validate a hypothesis. And so we set a p-value often a p is less than 0.05, so that when we run our test, we're assuming that if you're less than that p-value, then the null hypothesis is true. P-values are set a priori. It's very arbitrary, like p less than 0.05. So then if you're going to do a lot of statistical comparisons, you have to adjust your alphas. So then that's where you'll write in your methods, we've set it to this because of this. So it needs to state a priori what they're doing. because then you can go backwards, right? And you could be like, change it. So then a really good study will say, we realize we're going to do multiple comparisons. So we're going to adjust our alpha levels. And then they may have a p-value of maybe less than 0.001, so that we know that when you make multiple comparisons, you can actually run into something that we call is a type 1 error, which means that you run so much tests, eventually something's going to become statistically significant. So you didn't really find anything different between the groups, but you just ran everything under the sun, and eventually something's going to pop up and show like, oh, it's statistically significant. So there is a lot of things that can happen on the back end in statistics that you might have heard, like people will talk about where you can manipulate the data to get some of your findings. And so I always tell clinicians, you're looking at this study of these RCTs, okay, is there statistical significance between the groups? But also we need to look at it whether it's clinically relevant or clinically significant. Because if you see a change on, say, a patient-reported outcome that ranges from 0 to 100 and the change is 2, that's probably not a big deal to patients, a change of 2 on a scale of 100. And so then we would ask the question, well, is that clinically significant to patients? And there's a whole nother conversation of how you determine that and looking at psychometric properties of a patient-reported outcome to determine these values. But not to get into the nitty-gritty things, but we always just ask, this paper may show statistical significance, but also use your clinical judgment. Is it a big deal clinically? And I don't want to deter from the actual talk, but that is just some of the questions we could ask of these RCTs, where some of them will say we favor early surgery over managing things non-operatively in some of these outcomes. But if we look down at the raw score, it's actually not as big, I would say clinically significant.
Yeah. So is it correct to term it like this? For the trial, they found a statistically significant but clinically irrelevant difference in the KOOS score, which means that even though statistically speaking, there is a true difference between the groups, but then this difference in the score, technically speaking, once we look at how much of a change in that score or in that scale actually means something to patient, that actually doesn't mean a whole lot.
Yeah, and that was their conclusion. They stated that the effect seemed significant between the groups because the p-value was 0.026. But then on their KOOS, which is a patient-reported outcome, on average of 11.6. So it's a scale from 0 to 100, where 100 and you score higher, you're doing better. So they found on this, between the groups, there was 11.6 difference, but they don't know of the clinical importance or clinical difference between the groups. Is unclear.
Yeah. So there is also another systematic review published in 2022 that systematically, summarized these 3 high-level RCTs and did meta-analyses to compare the difference between early surgical versus non-surgical. Can you talk a little bit about what they found?
Yeah, so that's a really nice systematic review published in BJSM. Won't try to say the author's names because I probably will butcher it. And so a living systematic review just means that as there are more trials and more studies that get published, they're going to add to it and then update the study and the meta-analysis, which is really nice because then we can just have this really awesome synthesis of this really important question without having to wait for them to go through and constantly like the whole peer review process over and over again, which sometimes we do see is people will update a systematic review. And so at this point, what they found is that the risk of radiographic knee OA or osteoarthritis is higher, but the risk of secondary meniscal injury was lower 10 years after people have had ACL surgery. So this is maybe like a little shocking because people always ask me, if I have surgery, will my risk for developing osteoarthritis decrease? And that's actually a really big motivator for some people to get surgery because they think that this is going to delay or slow down osteoarthritis. And I actually tell them you may actually be higher risk because surgery is considered another type of trauma to the knee. And you also may have like multiple surgery too if you have complications from surgery. And so then it's not shocking to see that people who've had surgery seem to appear to have more radiographic knee OA. But it also makes sense why they have less risk of secondary meniscal injury because maybe the knee is more stable and so less likely to give away, which may lead to another meniscal injury.
Can you explain a little bit about why do we specify radiographic OA
Yeah, so we delineate osteoarthritis into radiographic, is just what you see in imaging, and symptomatic, which is what the patient experienced. And as you know, what the patient experienced is always much more important than what it shows on imaging. And so this just speaks to the complexity of humans and how they interpret pain and how they experience pain, because you can have someone with what we could say maybe severe and stage radiographic changes, but maybe not really experiencing that much or interpreting that much pain day to day. Versus some people may have minor changes on imaging, but experience way more debilitating symptoms or having more issues with function. So we know that there is not a strong correlation with imaging and symptoms. And that's why we do need to delineate that. We know that in the low back pain, we see that in every single body part. And so it's not surprising in the knee, it's no different. And so I always tell patients, if we're getting imaging in any body part, like take it with a grain of salt, because we don't diagnose off imaging. We use it to help aid our clinical decisions and what we may do next, but we don't say, you have this on imaging, this is what I'm going to do. And that gets a lot lost because everyone ends up getting x-rays and told they have osteoarthritis, but they have no symptoms sometimes. And so that's why in a lot of the evidence that you read, especially recent evidence, they'll have this strong delineation if possible, because 10 years you may have radiographic knee OA, but you might not be complaining of anything. And so we really do need to see longer term studies, maybe 20, 30 years, to really see, when do patients get radiographic knee OA? When do patients get symptomatic knee OA? And then maybe long term, is there a better correlation between the two as we progress on?
And why do the idea is that, oh, if your knee's more stable, there's less kind of like weird movements that's going on in the knee. Theoretically, that should be better for OA. Why isn't that the case?
Yeah, so we know that the ACL is the main stabilizer of the knee joint. And so if the knee continues to buckle and is not able to allow the patient to return to their function without giving way, then most likely there could be further damage to the healthy structures. So the way I describe it to patients is that your ACL is torn. You're not re-rupturing your ACL when your knee gives way or it buckles. You're going to maybe injure something that's healthy. And most likely, usually it's the meniscus, because we often think of them like as cushions, but they also aid in stability and stabilizing because they help to make the joint fit more congruent. So they do have these secondary roles in stabilizing too. And so if your knee is stabilized with an ACL reconstruction, then it most likely means you're not going to have potentially further injury to meniscus, because you maybe have less giving way episodes. And that's why there is this group that may need surgery even after rehabilitation. Because if you look at the RCTs and their criteria for you to move on to surgery in the delay group, it is after you've had a really good bout of rehabilitation, your knee continues to experience true instability. So we say you're doing like a pivoting activity or twisting and the knee gives way. Versus muscular instability, which is what I see all the time. People are like, oh, when I stand, my knee hyperextends because it doesn't feel strong. So we do need to figure out what type of instability people are really experiencing. Because if you continue to have instability episodes, those people do really well stabilizing their knee and having surgery most often.
Mm-hmm. So going back to the systematic review, with the two findings about surgical group may have more chances of developing radiological knee OA, but then they could have better meniscal outcomes. They caveat that as very low or low certainty of evidence. Why is that, given the 3 high quality RCTs? And how do we interpret that?
That's because there's a lot of other studies involved as well. So it's not just the 3 RCTs. So they have lots of different observational studies, they have case series. So they have a variety of different studies. And so they're pooling all of that. And so even though there's these 3 emerging RCTs that are available, there's still tons of other studies that are not high quality. So it kind of makes the conclusion a little bit more murky. And so that's one of the reasons why they come to their conclusion about the low level of certainty of evidence right now. And so it's just because it's really hard to run an RCT long-term and conduct it in a variety of different environments. As you know, like one of the studies took like 5 years. And also, I think a lot of studies have follow up to 2 years, but they're just starting to slowly get closer to 5. And only the Canoe trial really has 10-year follow-up data. And this systematic review is looking at their primary goal is looking at long-term outcomes. And so then really any of the data that we have beyond 10 years, mostly all of them are probably more observational studies and not RCTs.
So maybe just one more question on particularly research to help audience understand why are all these terminologies popping up and how we interpret them. What quantifies or qualifies as high quality study?
There are many ways to evaluate this. So we're looking at a systematic review. They will use a variety of different tools, an appraisal tool, so you can look at the bias within a study. So do you want some names or?
Put it in terms clinicians would understand.
Yeah, so you want to look at the bias within the studies because every study, even if it's an RCT, which we think is like the gold standard for determining whether an intervention is effective, it could still be done poorly. So we need to evaluate just that RCT alone and how much bias it is within that RCT. But then we also need to look at, in general, our conclusions, say, about, like you said, the level of certainty of a conclusion we make, because that is more relevant for clinicians. Because I could say this study has high or low bias, and a clinician will be like, okay, it's a good or bad study, but what do I do? But if I pull a bunch of different studies to say, look at an outcome such as OA, I really do want to know if the conclusion is like surgery is going to lead to higher risk of OA. How confident are we as clinicians with that conclusion as more studies are published? Because if we say a low level of certainty, really what it means is as we get more higher quality studies that have less bias, that conclusion may change. And that's where I think a clinician just needs to, today, some of the conclusions some of these studies are making may change because the current body of evidence is not high quality, which means there's probably a lot of bias. And then we start conducting better studies, we may change what we're saying. So it means we should stay on top of research and be open to maybe changing our messaging if 10 years from now we realize, hey, maybe surgery is better or non-operative is better. I don't think that's going to change, but that's when we discuss level of certainty in some of these systematic reviews.
Good. So given our discussion on what are the current evidence are talking about and where they at, let's put that into practical. Practically, how do we use this evidence and what kind of messaging should we be giving to clinicians? So I think the recommendations given the current evidence is that we should focus on shared decision-making. How do you typically go about that?
Shared decision-making is really when everyone at the table comes together to help make a decision, with this scenario being the patient is at the center. So it really overlaps with patient-centered care, which many of us are striving for. And I think the biggest way in order for patients to have shared decision is that they do need to be informed and have all the information. So we have to summarize everything based off the systematic review and the 3 RCTs, is that there are different options for ACL injuries, and it's not just surgery alone. That's the only option. And that we know that even based off the systematic review, that you have a good chance of actually maybe returning back to sport, having a good function of the knee, and maybe the same level of osteoarthritis across all the 3 groups. Because that's usually the question you'll get is, if I choose one or the other, am I going to go back to sport quicker or more likely to go back to sport? I'm going to get less osteoarthritis. And we see that all the clinical outcomes across the 3 groups stay quite similar across time. So that's kind of reassuring for patients knowing that. So now the question is, what do you choose? And so I find that this doesn't work well if the patient doesn't trust you. So if you don't have a relationship. So this is one of the reasons why I don't often have this conversation until we've seen them for a couple of sessions, got to know each other, because then they're more likely to like sit down and have this conversation with you. So building that therapeutic relationship. And then, like I said earlier, you're starting to factor in different aspects of their life. So number one is obviously, what is their goal? Like, what do you want to do? And what you want to do, does that need a super stable knee, such as sports that require a lot of pivoting? Does your work require high demand, and without a stable knee, you're at risk for injuries? So people working from heights, last thing you want is like climbing a ladder and your knee buckles, right? So I think the first and foremost is looking at what the patient wants to do and what demands of their daily life, work, play is required. So figuring out your goals. And then from there is, again, building on that mental and physical capacity of them to be able to either commit to rehabilitation. Because all 3 options requires commitment. It's just that some may be longer, because after surgery, you have to recover from surgery, which maybe delay your return to sport, versus non-operative, you just kind of keep going, right? So you don't have this delay in like having to recover from surgery, which is why you see in the data and in the evidence that the non-operative group seems to always look better at first because they don't have to recover from surgery. So these are all different questions you have to ask people and figure out what they want to, because a lot of people, again, aren't aware that they could just do rehabilitation. And some are really excited that they get this option.
I think that's a really good point, that you may not have this discussion right off the bat because trust is so important in how they perceive this information. But how do you even just provide the three options like later in that therapeutic relationship? Wouldn't you want to give them like an expectation first?
Yeah, so usually, we talk about their diagnosis and then I actually ask how much information they want. I used to just spill everything, like tell them everything, and because I want them to know everything so that when they go home, they're not swayed by the internet or what their friends tell them. But now I'm starting to ask more, hey, what do you want to know today? And some people will just say like, hey, I just want to know what I need to do for the week. I just want to be able to work on making my knee feel better and then come back to this conversation. Some people will say like, yeah, can you just tell me a little bit about like, what are my options, or do I need surgery? And so I do think asking the patient what they want to know instead of assuming they want to know everything is actually really helpful, because then it saves you time if they're like, I don't really want to talk about the different options or surgery today. And that's actually very helpful, I think, also in fostering that therapeutic relationship. So you are still giving them information. It's just that I think you're giving them in a way they want. So do they want a lot of everything thrown at them? Do they want just snippets? I do a summary email with my patients. That's where I will post and tag information there. So I'll usually say, hey, this is what we think is going on. It's an ACL injury. And then if you want some reading, here's some reading about the injury and treatment options, if you can read on your own time or if you want it. So I usually just always do that so they can have a resource, and then come back to different topics like whether they should have surgery or not, how long is rehabilitation as they're ready. But I always discuss about that rehabilitation is a criteria-based program. And so there are specific criteria. And usually on day one, I usually tell them that no matter what you pick, it's all the same criteria. You need to restore your range of motion. You need to normalize your gait and you get rid of the swelling. We got to make your knee feel good. We got to get you back to like living life kind of fairly normal, regardless of what you choose anyways. And they're usually pretty happy hearing that. And that takes off that burden and pressure of like, oh, I got to decide today.
That's great. That's really helpful tip to consult patients, what are their style of learning, right? One thing you mentioned is asking about their goals, whether they are wanting to return to pivoting sports or whether their work demands a lot on the knee. So do we know currently that if you are returning to pivoting sports, that it is better to have the ACL reconstructed?
No, I think this will come down to each person's risk level and what they're willing to risk. So say we have a scenario of a 16-year-old athlete who has this ability to be eligible, say at a very high level and get a scholarship for the NCAA. That athlete and the family and the parents may not be willing to take a risk of trying non-operative or rehabilitation only and then seeing what happens. So they might just elect like they want surgery because they're going to return to a very high demanding sport. Versus on the flip side, you can have a high level athlete, and this has happened quite a bit in the Winter Olympics, where you may have had an ACL rupture and you're 6 months out of the Olympics. So what you've been working on for 4 years. And if you have surgery, you're definitely foregoing your chance to participate or compete in the Olympics. And so we've seen many athletes choose just rehabilitation alone and rehab and exercise their knee like crazy and successfully actually return to competing and make it to the Olympic Games in a sport that is, like say we're looking at moguls, we're looking at downhill skiing, like they're able to do it even though we would say that's a high risk sport that requires a lot of demand. So we've seen it in ski cross, I believe. And so it's been fascinating to see these athletes and use these athletes as examples where they're in a sport that requires a lot of load to their knee, they're jumping and flipping from high heights, and they're doing well in ACL. So I do think there is a group of people who can be very, very successful in pivoting sports without an ACL. It's just that we actually don't really know how to determine who fits where. It's honestly a little bit of trial and error. But there are these factors, right? Like I said, are you willing to take that risk? If you rehab for a whole year, you go back and your knee doesn't do well. Some people are like, no, I can't sacrifice this year, right? So I do think this is like a very individual question, but we've seen successful athletes do it. For example, Hein Wards, who played American football, very successful in his career, was MVP, and he had no ACL, and he played football.
Yeah. Well, some people may say, well, these may be selected few examples of people returning to high-level risky sports without an ACL. Do we know currently about rates of returning to pivoting sports, surgical versus non-surgical?
Yeah, so we look at the return to sport rates after ACL surgery. It's also not 100%. We roughly usually say it's about 2/3 of athletes who have ACL surgery will return back to their pre-injury competitive level. So just having surgery doesn't necessarily foolproof you that you will go back to sport. So I think the message here is that the rehabilitation probably plays the biggest role in whether you're successful in going back, I would say, over the treatment or intervention that you choose. And we're starting to see that, I think, consistently in the evidence. But right now, it's because rehab is so diverse, right? Like what I do is very different from someone even down the block. And so when we pool these studies together, we're not really comparing sometimes apples to apples. And so I think that's why we're getting all these different findings. And then there's all this other route of surgical factors and what type of surgery you're getting and graft and all that other element too, right? So when we talk about return to sport rates, I try to group things into like surgical factors. There's personal factors. So some people maybe just have mom and dad had ACL tears, which we know there's evidence that you're more likely to have an ACL tear. There's a genetic component. There's personal factors, how motivated you are, the skill level of your sport, things like that. And then there's rehabilitation factors where what type of evidence-informed criterion-based program are you getting as well? Because if you're just doing balancing exercises for 12 months, it doesn't matter we wait 12 months. Your risk of re-injury may be quite high, even though 12 months have passed, versus someone who's done a really great program and they're 8 months, maybe their risk is actually lower, even though it's 8 months post ACL surgery. So time is important for healing of the ACL graft or the joint, but you also depends on what you do in the rehab. And so I sometimes try to look at it from those three factors, and that might help to determine what treatment, because if there's a little bit of personal factors that really groups you in a high risk of, like, say, re-injury, so history of genetics of ACL tears, you're naturally ligamentous lax, you participate in sports that are like really high pivoting, age, these little things, then that may lead you to potentially suggest ACL surgery.
Yeah, definitely we'll get into the rehab side of things, what evidence suggests that we practice. Before we get into that though, would you say that people going through the non-surgical route also roughly 2/3 of return to sports rate?
I actually can't say that. We know that when we look at the RCTs, there's no difference between the groups. So if we pause, I'll pull up one of the RCTs.
Yeah.
So when we look at the compare RCT and we look at the return to sport rate, so the number of patients returning to sport before their injury, so same level, in the early reconstruction group, so early surgery, about 43% will go back at 2 years. In the group that has rehabilitation and delayed surgery, you actually have only 31% go back. And then I don't know where the non-operative one is, because that will have to be done in like a post hoc analysis, which you don't have to have that. Because remember that the studies are comparing early versus delayed. That's the main point of the RCT. But then there's always this third group that ends up happening, which they didn't intend to, but it happens, which is rehabilitation alone. So what's shocking is that within these studies with recreational athletes, we're actually seeing a really low level of return to sport despite surgery, like 40% or 31%, and not the 66/3 that we're seeing. So the bottom line is, like, just based off that, it's just saying that surgery doesn't guarantee return to sport. That's what I think patients need to hear.
Or doesn't guarantee return to sport, but can you say that there is a slightly higher chances that you can return to pre-injury sporting level?
If the study compares that, yes. But remember that the main point of the studies are looking at patient-reported outcomes. So they are powered to look at whether or not we're going to find a difference in, say, the coups. So all three of the studies looked at some sort of patient-reported outcome. And return to sport is a secondary outcome. So it's not powered for that. So even if we see a difference, the study wasn't meant to answer that question. So it's just like a secondary finding. And we need to have a study that is asking, I'm going to run an RCT, I'm going to have 2 groups, and the main primary outcome is looking at return to sport rates at pre-injury level. Then we can, after that RCT, say this treatment is more effective at returning patients back to their sport then. So where we're at, we know that between the early delayed and rehabilitation alone, we're seeing that most of the groups aren't different in a lot of these clinical outcomes we care about. So again, just kind of reiterating that one treatment isn't superior, and that this is why it's so tough and so gray, is that we need to spend a lot of time with our patients to figure out what are the pros and cons of each and what's going to benefit patients the most. And that's not an easy process. And patients will want you to sometimes just pick, and you can't really, because it takes time to figure out. It's a big decision.
Yeah. I've also heard some say that no matter how much rehab you do, the muscular strength and everything, that can't compare to having an actual ligament in there. Like, how do you respond to this type of comments?
Structurally, it is true that you strengthen your knee, you're never going to be able to replace what the ligament does. But there are a lot of people that are able to perform and do the sport they want without a ligament in there. And I will use this comment. The history of ACL surgery has evolved so much. They used to do very vertical ACL reconstructions, which actually led to a pivot shift still. And then over the years, we then evolved to more an anatomical ACL, which controls the anterior and pivot shift of the knee. So they're getting more and more, controlling the function of the ACL, right? And then you're starting to see more additional things added to the ACL reconstruction. So to help stabilize the knee. So add-on surgeries, because they're realizing that maybe for some patients, just a primary ACL reconstruction that maybe stops the changes of allotment, maybe it's not enough to control some of the rotary or pivot shift instability. So then you're hearing things like an anterior ligament or an ALL or a lateral extratenodesis or a LET, right? So you're seeing some of those come in because they're realizing they need to add more stability to the knee. So if we go back to the vertical ones, I've had some patients who can show me their own pivot shift. So 15 years later, they come in, show me their own pivot shift. Potentially their knee is probably unstable, but they're like, my knee is great. And so this is an example where structurally, clinically, they probably don't have what we call a functional ACL, but yet they've had no complaints. So maybe those patients were actually managing non-operatively because they did not have what we would consider in today's assessment, an actual clinically stable knee. So I sometimes bring that up because that is a great example of where someone was able to function really well and probably didn't have a stable knee, like a structurally stable knee based off an ACL examination. So there is still always this group of patients that can do really well. And I have many patients that are able to perform and do all their activities in sports without an ACL reconstruction, and very happy.
I mean, it's a little bit like the ankle ligament where people sprain all the time, the anterior tibiofibular ligaments. Many people live without this ligament because it's been busted, but you can do so many things without it, running, jumping, volleyball, whatever, right? So maybe a little bit like that as well.
I would say that, remember, ACL reconstruction is still a really good surgery, still a good option for many, many people. So I think we just need to understand that there's going to be many different treatment options and that we need to help patients pick what's best for them. But if you have an ACL tear and your knee is unstable, ACL reconstruction is great because its job is to really help stabilize the knee. So I also don't want people to be like, I'm going to force everyone non-operatively, do rehabilitation only. Patients are complaining of instability, but I want them to not have surgery. So then they keep going down this route. If we look at all the protocols of whether or not you should have surgeries after, and the evidence-based guidelines, you rehab them, they have a quiet knee, functionally day to day, they look really good now. And if they're still complaining of instability, despite restoring the function in their knee, then you know what? Most likely they are going to benefit from ACL reconstruction. So don't assume that I suggest quite a bit of patients to have surgery, but I do think we have not given patients an opportunity to prehab, get their knee under control, and then let them make an informed decision. Because obviously if your knee hurts and it sucks and it's swollen and it feels unstable, you're going to think surgery is the best option. And I've had many patients who regret having surgery because they thought that was the only option as well. So just helping them make an informed and shared decision.
Yeah, I think that's a really important message to get across. The evidence right now, what we can see, it seems to be very equal, the 3 different options. And there are factors that are specific to patients that we want to consider and inform patients when we're helping them make the decision, not that we want to be biased on one over the other. So getting into the actual rehab a little bit, and also what does the evidence support in terms of patient education. You talked a little bit about having good rehab being an important factor to returning to previous levels of function. What is good rehab? Thank you for listening to part 1 of this interview focusing on surgical versus non-surgical ACL management. I hope this helped provide you with the most recent evidence on this topic. Paincast is a freely available resource to help you learn about pain and physiotherapy. To support our podcast, please subscribe and rate it on Spotify or Apple Podcast and share it with your network. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for part 2 of this interview.